So we're going to talk about basics of endoscope disinfection. And I'm delighted to have Selvi Tirumurthy, one of our colleagues at MD Anderson Cancer Center. She is the Director of Education for GHN. Laura Romero, who is the Chief Technician at MD Anderson Cancer Center. And I hope Kimberly Johnson could join. Kimberly is a Senior Technician at MD Anderson Cancer Center. And Sanji Suresh. Sanji is an educator. She has done a lot of work helping us in developing the program for endoscopy tech training at the Houston Community College. So these are my acknowledgements, and I'm grateful to John Stroline, Mr. Charles Butt, and I'm also grateful to Angela, Ms. Angela Deal, who is a medical illustrator. She has done an exceptional job in helping us developing the endoscopy tech training program, and again, Sanji Suresh. So these are my objectives, and what we're going to talk about is what is the scope of the problem in terms of endoscopy, infections in the endoscopy unit, why do they occur, and what do we do currently to prevent infection, and what needs to be done to improve the process. You'll figure out from this, you'll know that our process is not necessarily perfect, and there's always room for improvement. And finally, my thoughts, what simple measures could we implement in an endoscopy unit? So let's talk about what is the scope of the problem. So if you look at hospital-acquired infections, we may not realize this. It is a very big problem. About 1.7 million infections happen every year that are under the umbrella of hospital-acquired infections, with about close to 100,000 deaths, almost 99,000 deaths related to hospital-acquired infections. So, you know, right now we're in the midst of COVID pandemic all over the globe, and it has taken a lot of lives. And you can see 100,000 deaths from hospital-acquired infections is not a small deal, and that happens every year. So before we go any further, I want to give you a broad classification of the equipment that we use in the endoscopy unit or in the hospital. There are certain things that the patient comes into contact with, just the skin, that is patient's bed, BP cuff, pulse ox, etc., etc. And those pieces of equipment don't need much more than just cleaning and low-level disinfection. And they belong to what the Spalding described as non-critical equipment. And then in the endoscopy unit, you have the scope that goes into the body and contacts the mucosa. It does not penetrate the mucosa. And scope belongs to the semi-critical equipment, which requires not only cleaning, but high-level disinfection. In high-level disinfection, you get rid of almost every form of life except certain spores. You get rid of all viruses, all bacteria, and that is probably, that serves well for us. But when you think about if you're doing a a balloon dilation where you rupture the mucosa, or where you do a sphincterotomy, or you do a polyp resection or injection. And those are considered critical equipment, and they need sterilization. And that's the reason why those pieces come in a sterilized packet, and they're usually single use. So we understand about the three concepts: non-critical equipment, semi-critical equipment, and critical equipment. And endoscope belongs to semi-critical equipment, where you perform high-level disinfection. So when you look at medical device-related outbreaks, there are a lot of devices that we use during in the hospital. And as you can see, there were no outbreaks related to equipment such as vaginal probes, hysteroscopes, etc. There are a few that were related to transrectal ultrasound guided prostate biopsy devices or tonometers. And as you come down the list, gastroscopes and bronchoscopes account for majority of the outbreaks related to medical devices in the hospital. And that is a big deal. So when you look at endoscope-related infections, and this is a summary up to 5 years ago, 7 years ago. And if you look at the history, the first outbreak actually that was reported way back in the 70s and 80s was related to Pseudomonas aeruginosa. And at that time, endoscopy was relatively primitive. They didn't know what to do. And this was because of the water bottle that is used for air water insufflation, where they did not change the water, and the water became contaminated with Pseudomonas. Pseudomonas loves water, and that led to the first outbreak. And then there were some that were related to Salmonella, especially from one patient to another patient. And we also know that in the early phase of H. pylori infection, a lot of gastroenterologists got infected, but also when they were using reusable biopsy forceps with a spike, the biopsy forceps from one patient with Helicobacter pylori jumped to the next patient when it was used after just high-level disinfection. So what happened was they basically tried to rectify this by moving from multiple use biopsy forceps or reusable biopsy forceps to single-use biopsy forceps. Now almost every lab uses a single-use disposable biopsy forceps. Then when you come down to HCV infection, there was lots of outbreaks. The biggest outbreak was in Nevada, in Las Vegas, where a practice was using propofol vials, the same syringe and then same bottle for multiple patients. And that led to a big outbreak of HCV, and it became a big medical legal issue, not only for the group, but also for the society. So since then, we have actually changed to single-use vials. In the last 5 years, the CRE infection became a big issue, although there were several outbreaks prior to that. And then if you look at it, bronchoscopes also account for a lot of endoscope-related outbreaks. So you can see from here, this is a problem. So then you ask yourself, why do infections occur? And if you look at it, why do infections occur? It is a very complex problem with multiple factors. And when you think about it, although we knew a lot about it, but the CRE outbreak, that is CRE means carbapenem resistant Enterobacteria outbreak, that happened in Chicago in 2013-14 time, led to extensive work by CDC. You must understand this. CDC does great work. Whenever there is a multi-drug resistant bug in any hospital and they think that they have reached a particular signal, they actually come down and investigate, and they actually did a lot of work to define the reason for the CRE infection in that hospital. And this paper came in JAMA in 2014, and I would encourage anyone interested in how one investigates an outbreak of infection. This is an article to read. It's a beautiful article, and you will figure out how they traced the infection from one scope to the next scope, or from one scope to a particular patient. So after the first outbreak, there were several outbreaks, several infections, and also deaths. My colleagues from Los Angeles, Seattle, and on the East Coast were all in the newspaper because of the CRE infection. And that has excited a lot of people to do some good work to prevent this infection in our endoscopy units. So whenever a big serious problem happens, FDA becomes involved. And what they did was in 2014-15, they brought together experts from gastroenterology, endoscopy, industry, infection control, as well as CDC and FDA. And they had a big meeting, and they looked at all the factors responsible for infection, and they pointed it to endoscope reprocessing as the issue. When you look at endoscope reprocessing, there are two things. One is the design. They felt that there is a problem with the design. We need to fix this. And we did fix this. You'll hear that as we go on. And then they also felt that there is a human component. And I'm going to talk about the human component in detail. So they made two recommendations. They said we need to fix the human component, minimize or completely eliminate the error, and we need to redesign it so that the design allows the humans to perform better. So Andy Ross is a good friend of mine. He's the chief of gastroenterology in Seattle at Virginia Mason. So what he did was he was one of the pioneers in this area. When he looked at endoscope reprocessing, from the time you do the pre-cleaning to high-level disinfection to storage, when he looked at it in ERCP scopes, there was a 2% reprocessing defect. So that means if that defect happens in a scope that results in contamination, you will expose the next patient for infection. And when you look at 650,000 ERCPs, that's the number that's done in the US per year. And if you check 2% of 650,000, it exposes 13,000 patients to infection. Whether it leads to infection or not, we don't know, but that's going to be the exposure level with the 2%. If you increase it to 4%, that it increases further. So we want to make it 0% reprocessing defect. So that we can tell the patients, every patient that's coming into the endoscopy unit, we can take care of you safely. So when you look at it, there are three basic principles that we need to understand. The scope goes through the gut. The gut has a lot of bacteria, and we will talk about that. Then the scope has a design that is difficult to clean. We will talk about why it is difficult to clean. And then what happens if you don't reprocess the scope properly, and there's going to be biofilm, and the biofilm gets more contaminated each time the scope goes into the gut, and because you don't clean it properly, this cycle keeps on going, and it becomes extremely difficult or almost impossible once heavy biofilm develops. So we're going to talk about these concepts. So let's talk about gut bacterial contamination. So as you can look at it, here is the gut, starting from esophagus to the rectum. And if you look at it, the microbiome content of stomach, small intestine, and colon. So this is the microbial load. As you can see here, as we go from stomach to the colon, it increases. So if you want to actually remember this easily, so stomach has about hundreds of microbes. When you go to the small intestine, it goes to thousands. When you go into the lower small intestine, close to the colon, it goes into millions. And then when it goes into the colon, it becomes billions per ml. So a lot of microbes. So you can see how easy for a scope to get contaminated. So this is an important concept to keep in mind. So let's talk about endoscope design and why is it difficult to clean. So when you go into an endoscopy unit, you can see there are lots of different scopes of different lengths and different caliber, and then different special functions as you go to the ultrasound scopes and the duodenoscopes. So first of all, the scopes are very complex, and they do have channels that need to be cleaned, and you need to use the right brush, and you need to use the right technique. So we're going to talk about why is this information about scope design important for every person dealing with scope cleaning. So when it comes to channels, there's not one channel, there are a lot of channels. You have channels for air, you have channels for water to clean the lens, you have a channel to clean the lumen, that's a water jet, and you have a channel for suction of both air and contents of the gut. And then when you come to ERCP scope or a therapeutic EUS scope, there is another function that is the elevator with its own channel. And that elevator channel has made a lot of problems, has been responsible for majority of the CRE infections that we encountered. So let us look at the channels. As you look at it, we have already talked about it in the last couple of weeks ago about the channels. We have channels for air. So that's the air nozzle, and you press the air valve. The air comes from here and it goes, as you can see. And this is a channel, as well as the water channel, again the same path. These cannot be brushed, and these can only be flushed during the cleaning process. These are not accessible for brushing or and trying to clean the channel. And that's one reason your water has to be very clean and sterile. And you don't want to put anything into the water bottle except sterile water. So next is the suction channel. And this is the suction channel that goes from here. As you can see, it has a long path. It has an accessory to go to the biopsy channel, and then it goes to the button here, and then it takes a right angle, and then it comes down, it takes a right angle, and it comes out. As you can see here, these channels are very long, and they take multiple turns. And the reason why you have to think about long multiple turns is when you clean the channel, you have to think about whether you can touch the surface when there is an angulation with your brush. So if you don't touch a particular surface, you are going to leave that surface contaminated and a biofilm will develop. And then the water jet channel, as you can see here, the water jet channel is another channel that you cannot access with a brush. The reason why this is important is, well, previously we used to put simethicone in the water jet channel, and that simethicone can actually create a biofilm. And you know that the water jet channel cannot be brushed to get rid of the residue of simethicone. So that's why we actually stopped using simethicone in the water jet and instead put simethicone from here through the biopsy channel, and that biopsy channel can be brushed and flushed. So something to keep in mind. So let us review the structure of the scope. So you can see the biopsy channel, and I'm going to talk about two things. The biopsy channels come in different sizes for different scopes. And why is that important to know? So as you can see here, for a gastroscope, your biopsy channel can be as small as 2 millimeters to as big as 3.7 millimeters. I'm going to talk about why is that important. For colonoscope, from 3.2 to 3.7 millimeters. For endoscope, 2.8 millimeters. For ERCP scope, it's a big channel, 4.2 millimeters. And the US scope, 3.7 millimeters. Why is this important? Say, for example, you have a small channel. Like most of these scopes have 3.7, 3.7, 3.7. Say, for example, it's a 3.7 millimeter channel, right? That is an EGD scope or a colonoscope or a US scope. Then you have an ERCP scope that is 4.2 millimeter channel. Why is this important? Say, for example, you use a brush that is made for 3.7 channel. It is going to clean that channel. But if you use the same 3.7 millimeter brush, what is going to happen? You are not going to clean the channel and you're going to leave residue. So it is important to pick the right size brush for the right channel. And unless somebody is very particular in taking that precaution, you could leave a lot of stuff in the biopsy channel. And once you leave and create a biofilm, it's not going to get better. So that's a very important concept to keep in mind. So the next thing is, as you can see here, you can see the scope, you can see the biopsy channel, and you have a water jet channel, CCD signal channel. There are a lot of other things surrounding the biopsy channel. Say, for example, there is a leak from the biopsy channel, and you do not do a proper leak test. What's going to happen is the contents are going to come out and contaminate the scope, and that area that is contaminated outside the channel, even if the next person tries to do a good cleaning, is not going to get rid of the bugs that have come to outside the channel. And that scope will be a source of infection for a lot of patients. So leak test is really critical from this concept point of view. If you don't do the leak test, another costly thing is you can destroy the fibers and it could be a very costly repair. So these two concepts are very important to keep in mind. So let's look at ERCP scope and EUS scope. And if you look at this elevator channel, the elevator channel actually revolutionized GI endoscopy. When they created the elevator channel, they were able to help patients that would have otherwise required surgery, like say, for example, gallstone patients or patients with pancreatic disease. And those two problems were never, we could not have managed if somebody did not devise the elevator channel. So that has completely changed the role of endoscopy in terms of, or expanding the role of endoscopy into the pancreatic or biliary disease management. But at the same time, the elevator channel has become a big problem for endoscopists because this area is not easy to access if you want to clean. And a lot of times it is very difficult to reach this undersurface of the elevator. And junk can sit in the undersurface of the elevator. And if you cannot clean that elevator, that becomes a source for infection. So something to keep in mind, because this elevator channel has been responsible for the CRE and multiple ERCP related infections. So in the last 5 years, I should actually congratulate FDA and all the companies that worked to fix this issue. We're going to talk about that. All right. So next one is, we talked about gut. We talked about design and some of the issues. Now we're going to talk about what happens if you don't reprocess and it leads to biofilm. So what is biofilm? Biofilm is a film of a biomaterial. It could be protein, it could be fat or whatever that sticks to the lining of the scope. If you don't clean it properly, and if you do not clean it immediately after the scope comes out of the patient. So it's like a cup of coffee. You drink a cup of coffee and you become a little bit lazy and you don't want to clean it immediately. Then you have to clean it much longer to get rid of the stuff that gets stuck inside the inside that cup. So once you have the proteinaceous material, the bacteria like to settle in there, and then as they grow, they create what is called a biofilm with time. So you can have a brand new scope and not clean properly. You can create a biofilm right on day one. So something to keep in mind. So the key is to clean a scope immediately. That is the most important thing. And then properly. We're going to talk about these two concepts to avoid scope-related infections. So what do we do currently to prevent infection? So the goal is to avoid having a biofilm. That's the goal. And you can get it if you can have a clean scope and a scope that is dry after cleaning so that bugs don't get back into the scope. So let us talk about it. So here is an endoscopy unit. You have the reception area, you have the preparation area, you have scope rooms, and you have on the back side things like the kitchen, right, where the scope cleaning happens. One of the problems that I've noticed in many endoscopy units is this. We actually make multiple rooms, but we do not create enough space for scope cleaning. I personally, I don't have calculations. By intuition, I feel that if you have an endoscopy unit you want to design, you should have like a about one third in the preparation reception, 1/3 of the rooms, and about the same size of what you occupy in the rooms should be for your, at least the scope cleaning, scope drying, and storage areas. We do not do that. Most units don't do that. Now with COVID, you have to keep one thing else in mind. If you want to design an endoscopy unit into the future, you should have a lot of space for your endoscopy staff to actually have a break so that in the future, when we will have more respiratory infections or pandemics into the future, we can actually protect ourselves better. Right now, almost every endoscopy unit in this country is probably suffering by not having enough break room space for their staff. So what happens? All right, once the scope is done, it comes into the soil scope cleaning area where the scope gets clean. We go into the details, and this is what happens. So once the scope comes into this into the soils scope cleaning area, the first thing that happens is a leak test. And then after the leak test, you go to the sinks for manual cleaning, where you get rid of a bioburden. And once you do the manual cleaning, you inspect the scope to make sure that your cleaning has gone well. Following that, you take it to the high-level disinfection area where you put them in the processor for high-level disinfection. Subsequently, you take them to the drying area for scope drying, and then to the storage area, and then back into the rooms. It is a complex operation, as you can see here, lots of steps that need to be done by endoscopy staff who manage that part of the operation. So let me take you through these steps one more time in a little more detail. So as you can see here, what happens in the room, what happens in the cleaning area, what happens in the drying area, and what happens in the storage area. And these are the multiple steps that we follow every time a scope goes through a patient and then gets back into another patient. So in the procedure room, once the scope comes out, we do what is called pre-cleaning. And pre-cleaning is outside, removing debris and microorganisms, and then inside by flushing the channels with a specific detergent. And that is really important to do. One thing that is more important than pre-cleaning is timing of your pre-cleaning. I personally feel, and the data shows, that it should be immediately done. You know what is immediately done? That means scope, when it comes out, it should be done immediately. Does it happen all the time? I'm not sure. If somebody is doing an EGD and a colonoscopy on the same patient, once the scope comes out after doing an EGD, it should not be put aside for pre-cleaning after the colonoscopy is done. It should be done as soon as the scope comes out of the patient. Like we talked about cleaning your cup of coffee after drinking coffee, right? You should clean it immediately. If you do not do that, there's going to be biofilm formation, or at least a film formation that will be very difficult to clean later. One of the problems that I see is endoscopists may be in a rush because they need to do their procedure and get out and put the report, and they may not have patience to wait for the technician to clean that scope between the two procedures. And this is one thing that endoscopy administration should put their foot down and say, once the scope comes out, that will be cleaned immediately, and everybody waits for the technician to do that cleaning, and it has to be done. The next is you take the scope to the scope cleaning area where you do the leak test. So the leak test is basically, there's a machine here, and the machine is hooked to this leak test connector, and you set it for a few minutes. It pressurizes the scope, and when after a few minutes, it tells whether it's a pass or a fail. During the testing, one of the things is you have to keep your scope loosely coiled, and then after a while, it signals and says, turn the knobs, right, left, up, down knobs, press on various buttons, and as per the instructions, you do that, and then the machine will spit out the scope has passed. If the scope has failed, there is a protocol and that we will talk about it in the next class. And this leak test must be done before the scope goes to manual cleaning. If you do not do the leak test and there is a hole, that scope will be flooded during the cleaning process. And it could be a very, very costly repair. So it's very important to do the leak test and then document that you did the leak test before the scope went for manual cleaning. The next step is manual cleaning. Manual cleaning, the principles of manual cleaning is you clean the scope underwater, immersed underwater, and then you do two things. You brush the channels. The channel that you could brush is these air water suction channel or the biopsy channel, and then all the ports, the caps where you put and the valves you put, you brush those areas. And then once you brush, you flush with specific agents, and that will flush all the channels, even the channels that you cannot brush, air, water, water jet, etc. And then you clean the scope outside as well. So this is probably the most labor-intensive part of the whole high-level disinfection. And it does take a lot of time, and it does take a lot of water. Each tank, you clean it in 3 different tanks, and each tank will take at least between 8 to 10 gallons of water, along with a lot of detergent to clean that. Once the scope comes out, you should do a visible inspection under a magnifying glass. And especially with an ERCP scope, you should inspect under the elevator to make sure that there's no residue. And you also look for any cracks, or if there are cracks, you may want to not put the scope in the machine for high-level disinfection. You need to take it back send it back for repair. And if you see any retained debris, you go back and do manual cleaning. Because retained debris cannot be cleaned by putting it in a machine for high-level disinfection. Sometimes people notice this when a scope goes through the process, and then when they come out, when they're trying to put the scope in and they flush, and they can have specks of material, right? You want to make sure that you take time to do that inspection, like an inspector does. And finally, you put them in the high-level disinfection unit. This is where you need to think about the contact time and the concentration of the agent that is being used, and they meet the criteria. And here, you get rid of whatever remaining bugs that are left, and they kill the microorganisms, they kill the mycobacteria, they kill fungi, and then viruses. So, as you can see, this is a very labor-intensive process, and once the scope comes out of the high-level disinfection, you take it and do drying, and the drying should be done for 10 minutes. It's not putting a little bit of air for each channel and then say, okay, I've done the drying. That's not going to work, because if you do not dry for 10 minutes, there is going to be water in the channel, and that water can attract Pseudomonas. So it's very important that the channel has to be dried for at least 10 minutes. Following that, you take it and store the scope. At Anderson, we are fortunate to have a special storage area with continuous drying, where there is air, filtered air, that actually goes to all the channels through tubes, and there is continuous flow of air that allows the scope to remain dry. The goal is to have a clean scope and a dry scope. These two things are very important to maintain an endoscopy unit free from endoscopy related infections. So you need to figure out how do we make sure that we reach this goal for every scope. All right. What needs to be done to improve the process, right? If you're doing all of these things, we should not have infection. But we do have infections. We had infections. So what needs to be done to improve the process? So that goes back to this outbreak in Chicago. And FDA, like I said, convened a lot of experts in 2015, and they came up with 4 important recommendations. The first one is focus on the reprocessing staff in terms of oversight, in terms of training, and in terms of making sure that the reprocessing staff is competent. That is something we should assure we should make sure that it happens so that we can assure the patients that we do have a good team. And this is the Achilles heel for any endoscopy unit. The next one is they talk about pre-cleaning and manual cleaning, that we should make attention to pre-cleaning and all the cleaning steps before high-level disinfection, because this is the human component that could lead to problems. And the third one is to adhere to manufacturers' instructions for use, especially cleaning brushes. We talked about why is this important, right? If you take a small cleaning brush for a large channel ERCP scope, you can document that you brushed the channel, but you have not helped anybody because that brush is not even brushing the channel. It's just going in and coming out. The second thing is you have to have the scope when you are doing the brushing in the sink loosely coiled and not tightly coiled, so that as the brush goes through the channel, it contacts the entire surface of that channel. That is really important to do. And finally, we should have accurate record keeping so that we could track if an incident were to happen with a particular scope. We have this obligation to make sure that we provide the best care for our patients. So let's talk about it. Okay. Say, for example, a scope comes out and it is maximally contaminated. And for some reason, the endoscopy technician is tired, maybe cleaning the scopes at 10 o'clock, and they've been in the units from 8 o'clock that day. At 10 o'clock at night, they may be tired and they may not followed every step. And then the cleaning is a little bit suboptimal. You would lead that amount of bacteria in the scope. So there is a low margin of safety, especially with reprocessing. So these are things we should figure out a way to address. There are a couple of studies since this CRE came out in 2015. There's a large Dutch study where they looked at 72 centers, 309 scopes, 64 US scopes. And in their study that has just come out in 2020 GIE in press, they found a scope contamination of 15%, irrespective of the age. It doesn't mean whether you have a new scope or an old scope, whether the scope is used once a week or 5 times a week. It doesn't matter. If for some reason you don't follow the protocol, there is a contamination rate. There's another study that's also very interesting. That's again, that also came in GIE in 2020. What they've done is, this study came from the US. They have followed manufacturers' recommendations, MFI, right? the manufacturer's instructions. So the initial high-level disinfection is not always effective at eliminating bacterial contamination. So they saw that in their study, 18% were culture positive after first HLD, but it kept on decreasing after repeated HLDs. But this is something to keep in mind and figure out how do we minimize or avoid this problem. We know that scope cleaning is labor intensive. And how do you know that somebody cleaned the scope properly? You know, except believing that they have done all the steps. There is, unless you have a way to test the quality, you won't know whether you're following the process so that you have a clean scope by the time the scope comes to the storage. So we have opportunities to do that. There is a test called ATP test. It is a simple test, and it looks for bioburden, and it takes 5 minutes to do the test. And what you do is you do the pre-cleaning, leak test, manual cleaning, and during the visible inspection, you do the ATP test, and if it passes, you actually send it for high-level disinfection. If it fails, you go back and repeat the process. And by having this test as part of our routine, it will help us figure out whether our cleaning process is up to the mark or not. If you have somebody new who's coming into the system for cleaning your scopes, you would use this test to help that person train properly. And I believe this ATP test has a lot of value in endoscopy units. So how do we minimize infections? So after the CRE infections happened in 2015, there was a lot of interest in figuring out how do we actually assure our patients that we could minimize infection. So this is a beautiful study that came from University of Pennsylvania. And the most important thing is here. Although they used quarantining of scopes, more than quarantining of the scopes, what they have done is they've set for themselves from pre-cleaning to manual cleaning, it should happen in 1 hour. From manual cleaning to high-level disinfection, it should happen in 1 hour. That means they are actually on that scope to clean it promptly and fast so that they prevent biofilm development. So I think this has made a big difference for them. So once a week on a Friday, they took 25% of their scopes and they put them to the culture. And if they're culture negative, they went back into service. If they're culture positive, you basically repeat the cleaning, quarantine the scope, clean it till it is negative before you bring it back into circulation. And as you can see here, their culture positivity is low. And this is probably because they have implemented this step. That is, as a unit, they said, from the time the scope comes out to HLE disinfection, it should happen within 2 hours. And it costed about, for them, they came up with a price, about $1,500 per year per scope, but you need a large inventory of the scopes. So what are the things that people have tried? Okay, one is you clean once, and then you go back and clean the second time from manual cleaning again. That is repeat reprocessing. And when they did the ATP test, it was by repeat reprocessing, it is similar to what you would get by checking sterile water. It's almost, it is absolutely clean scope. So that's one concept people have talked about. Another concept is they did a repeat high-level disinfection. So you do the high-level disinfection, take the scope and put it back again. And what I've shown is there's no difference by repeat high-level disinfection because their original cleaning is very good. So if your original cleaning is so good, then these other steps don't mean much. So that is the most important point I want to make. So when the CRE came, people talked about gas sterilization with the ETO, but this is not going to work because of the risks that it can pose to the people that use ETO and not readily available, and it takes a long time. This is not going to work. They talked about liquid sterilization with the paracetic acid. Again, it's not proven yet, so we don't go there yet. So say, for example, you don't have a lot of resources, right? As culturing, quarantining is costly. And if you don't have a lot of resources and you say, I still want to play safe, is you screen your patients. If a patient is MRSA or CRE positive, the patient goes through a procedure and the scope comes out. And once the scope comes out, you culture that scope and you do not put that scope back into circulation until you prove that scope is clean and free from infection. So screening patients for infection is probably a simpler option. So having read all this, what would I do in my endoscopy unit or in your endoscopy unit that doesn't waste a lot of resources? So I would make it a point, an administrative executive order, to tell all my staff, my nursing staff, my technicians, my faculty, physician staff, that once the scope comes out, it doesn't matter whether you're going to reuse the scope, that scope is immediately pre-cleaned, and then there is a runner that takes the scope to the cleaning area. From pre-clean to manual cleaning, it happens in 1 hour. And from manual cleaning to high-level disinfection in 1 hour. In order to do this, you need to figure out your workflow and your setup. This is actually, if you can make it happen, you're not basically wasting a lot of resources. You're just changing your logistics of how you're going to operate. That's one. The second one is I would implement an ATP test for all the scopes, or periodically to check that the scope passed the ATP test before they go into high-level disinfection. Then last one is I would include culture and quarantine, maybe for high-risk patients who are positive for multi-drug resistant bugs, or if I have more resources, to do it periodically. I would put more resources here and change the mindset of people to allow the scope to be cleaned as soon as the scope comes up. And then go to this step and go to this step. And this will probably be something that could be implemented without a lot of resources and energy spent. So coming back, what are the things that happened since CRE came out? So industry came up with novel designs whereby you could actually use the scope once and for a particular patient and do not reuse it again. So the whole aspect of cleaning is gone. You don't have to worry. You take a scope like a single-use device, and after the scope is done, the scope gets disposed or recycled for something else or whatever. That's one. So that is single-use scope. The second concept that came was, and is now in place, is figure out a way to change the tip of the scope for ERCP scopes. So that the elevator we talked about, which causes the problems, difficult to clean, you get rid of that whole issue by changing the elevator. You have a scope, you clean the scope, but for every procedure, you put a new elevator segment. So that's, you can still keep your, still need to design new scopes with the new tips and then throwing away the tip. That's the second concept, scope tip. I believe all the major manufacturers of ERCP scopes are have a design for this, or some in production are already available in some countries. The next step is you don't do anything. You have the scope, but you actually put a sock into the channel to cover the elevator or the scope tip cover, and just put the sock to cover the elevator. And then once the procedure is over, you take the sock off, your elevator is still clean, and you process the scope like anything else. So this is another concept. Then you continue to do the same thing, but you make sure that you train your people so that every scope that comes out of the unit is absolutely clean and dry, knowing that there's going to be human error. So at this point, I would like to share with you some of the excellent work done by our group, the Texas Interventional Endoscopy Group. And Sanji Suresh did a nice study in 2019. We took 105 techs and nurses who attended the course, and we gave them a questionnaire on infection control. And this is what Sanji found. If you look at it, we tested whether they can put the PPE properly. We tested whether they have knowledge about infections caused by CRE and what is the channel that causes the infection, and then timing of cleaning the scope, leak testing, manual cleaning, and then how much of scope should be immersed for cleaning, when to test the disinfectant, and how long do you need to force the air. We talked about 10 minutes. That basically came just before. Maybe at that time, majority didn't know. And then we looked at the total score. So when you look at it, about 60 to 80%, right? If you look at it, PPE-wise, not very good. But thanks to COVID, now everybody knows how to wear PPE and take off PPE. But the score shows that there is still room for improvement, as you can see here. And we also looked at it and said to ourselves, what are the take-home messages that Sanji's work has offered us? It's very interesting. Majority of people had no prior training. Only 1 in 4 had prior training as a surgical or a sterilization tech before they became an endoscopy tech. And it's also interesting that 1 in 2 start disinfection of scopes within a month, after a month of training. And only 1 in 3 actually had certified in endoscopy reprocessing. And when we asked their knowledge-wise, they all felt very confident, but their knowledge was lagging by about 40%. So as you can see here, there's a lot of room for us to help with education. And the Houston Community College is planning to start its first batch in spring of 2021. So at this point, I want to stop, and we'll open this thing for any discussion. And I really appreciate your time.
Thank you, Raju. That was great. Very informative. I learned a lot. I see that we have some participants that I would like to see if they have any comments.
So they could send us a chat, or they can open up and ask questions, whatever works.
Okay. So people have been asking questions throughout the talk, and then Laura's been great about responding to those. I see that Denise Behringer, our Center Director for Operations, has joined us. So I wanted to see if she has any comments or any feedback about how scope reprocessing works at MD Anderson. She's our endoscopy center director. Denise?
Good morning. How are you guys?
Hi.
Can you
Good
hear
morning.
me?
Yes, we can.
Okay, great. Thank you, Dr. Raju. One of the things that we recognize at MD Anderson that we need to continue to focus on is that time to reprocessing. We recognize that that is something that we can improve on, and ensuring that we've kind of changed that culture so that everyone is, once we finish with one scope, we're immediately reprocessing or immediately doing the first step to that reprocessing and getting it to the scope room quickly. The other thing that we are looking at doing is adding the ADT testing. That is not something we currently do, and we see that as a real opportunity for our program to make sure that we have that extra step in following that manual clean. So I'm hopeful that we'll have that first of fiscal year, this next starting September, October, and that'll add to our process. We're very fortunate, I think, at MD Anderson because we do have the resources available to often get what we need, and we've got some really, we've got Dr. Raju and others, Laura, who keep us informed and keep pushing us to move our reprocessing to state of the art. So those are just my initial comments. I don't know if Laura, if you can speak to, I was thinking as Dr. Raju was talking, what is our time to reprocessing? We keep that data. So I'd be really interested to kind of start looking at that time to reprocessing for manual cleaning.
Good morning. We don't have a data of how long it takes the scope, but of course we follow the manufacturer recommendations and infection control, and plus the enzymatic detergent time. So that's adding extra time. So that's how we process our scopes. So we follow, like for the, especially if we are reprocessing the duodenal scopes, we have to do the leak test manually, and that is recommended per Olympus. And then we have to do our manually cleaning. We added another minute, which is the enzymatic detergent is recommending. And then after moving from the first basin to the second basin is another minute. So all you have to do is just make sure that you follow what the recommendations are from your manufacturers, depending on what enzymatic detergent you're using, depending on what scope are you using. Just follow those guidelines, because those are very important in order for you to process your scope correctly.
Great, thank you so much. I wanted to see if Dr. Satikno had any comments on the talk and talk about his experience in his endoscopy unit. Dr. Satikno?
No,
Good
it was
morning.
a great talk. I really enjoyed it. I think the one difference that many units may have is that the pre-cleaning in some units are done in the room. Do you want to comment on that, Raju? You're recommending that the pre-cleaning is done in the reprocessing room, in the dirty room. Am I correct?
No. We do pre-cleaning in the room itself, and I put it as operating room pre-cleaning. You know, you should do pre-cleaning immediately as you suggest, right? And that's what we do. The moment the scope comes out, while we are in the room, while the patient is being turned from like an EGD to colon, we do the pre-cleaning.
I think this is where we probably need to put extra efforts, as Raju had mentioned, that in many instances, we have a double procedure, whether it's EGD colonoscopy or with an EUS and upper and then ERCP. All of these scopes are stacking in the room after they're being used, and they stack for longer than the 1 hour recommended time. And during that 1 hour, then you have biofilm development. And once biofilm develop, it actually takes time to immerse the channels so that the biofilm can become soft and can then become brush away. I think that the time is like many hours to immerse it. Can you elaborate on that?
So the thing is, what Dr. Sitekna is talking about is, if you do not, if your scope gets delayed to getting manually cleaned within 1 hour, like say for example, you have a bunch of scopes to be cleaned, and say for example, this is what happens typically, right? You have 8 or 9 rooms going on, and then almost everybody finishes their scope at the same time. Say for example, that happens, or maybe half of them finish. About half a dozen scopes come at the same time, and well, if there's no personnel there, then the scopes are sitting there for longer than an hour. If that happens, taking them through the manual cleaning process that we talked about doesn't work. You have to take them through a different pathway of soaking the scope for extended periods in a separate tub. It's like, you know, if you don't clean your cup immediately, you have to soak it with water. It's the same concept. And that is the only way to actually get rid of having the biofilm development. So I personally see this, I see this problem in different endoscopy units where an advanced endoscopy team is doing a very complex procedure that may require the use of 2, 3, 4 scopes, right? And all 4 scopes are sitting there for 2 to 3 hours. Some scopes can go on for 2, 3 hours. And if we do not have a system to say, okay, once the scope comes out, you are going to get a new scope. It's almost like, we can't go to any buffets, but you take a plate and then you take a new plate. It's the same thing. If you take the scope out of the patient, that scope should go to the endoscopy manual cleaning after getting pre-cleaned in the room. But in order to make that happen, you need to plan for additional people to do the pre-cleaning so that the tech doesn't have to stop assisting the procedure. So these are complex things that need to be thought through to actually provide exceptional care.
Thank you.
Are there any either endoscopy nurses or technicians who want to share any comments, any limitations, things that they see that are going well in their respective GI labs? You can unmute yourself and then add your comments.
Andrea Thomas, do you have any comments on this? Tamitra is our infection control champion, and she works specifically in the scope room. So, she's just excellent. And when it comes to infection control, she knows everything.
Does she have any comments?
I don't know. That's what I'm asking her.
I'm
mute.
Okay. Demetria, I unmuted you. If you have any comments.
Oh, I think we lost her.
Can y'all hear me?
Oh,
Yeah, we can. Go ahead.
Okay. I was just trying to figure out how to unmute myself.
No, I took care of it for you, my friend. Good morning.
Good morning. Thank you, Dr. Raju, for the presentation. I did learn extra things as well for my knowledge and what I can do better for my areas in scope room. As far as anything, we try to stay in between the 1 hour window. With the COVID, everything has been a lot more simpler for us to make sure we get the pre-cleaning done in the room the manual cleaning within the hour, and the scope and the reprocessing machine within the 1 hour. So that hasn't been a problem for us. If we do run into such a problem, we do have the extended cleaning process that we do have, that we try to soak the scope for an extended period of time of an hour or more if needed. I think yes, sir.
I want to make a comment. Tamitria, I want to share with you that you do a fantastic job. I really admire the way you clean the scope. It's an art, you know, how you move your hands as if, you know, you're actually conducting an orchestra. I really admired doing the video shoot. And I also have to tell you that you have the guts to throw me out when more scopes came in saying that I need to keep up my time. I really appreciated that.
Oh, thank you. Yes, I try to, you know, I'm a one person in the morning, so I'm trying to stay on top of everything, making sure everything is reprocessed within the time frame. Exactly.
Yeah, I really admire that. I want you to know that specifically because, you know, the small things, you know, you need to put your foot down and say, this is acceptable, this is not acceptable. I really admired when you said, okay, I need to clean the scopes. We'll convene some other time. I really appreciate that. I want to invite Sanji to share her thoughts. Sanji has done some beautiful original work, and her abstract was accepted for presentation at DDW this year, and she's just submitted a paper on the same topic. Sanji, you want to comment?
Hi, everybody. So I just want to kind of reiterate what other people have said in that I think that while there are obviously certain people that do the reprocessing, the process is a team effort, and recognizing that there are strains that are put on the people who are reprocessing that need to be taken into account as a team during procedures. For example, as other people have said, ensuring that those scopes get cleaned in between back-to-back procedures and such. I think in regard to the research that we've done, I think that there just needs to be ongoing efforts to ensure that people are up to date on the different techniques that can be used to improve the process. As other people have said, we have a long way to go and ways that we can improve to make sure that patient safety isn't at risk. And so having more in-service training, having opportunities like this to gain refreshers and to learn new things that are coming about, I think is really important. So.
Thank you, Sanji.
Very interesting study.
Thank you.
If there are any other questions, feel free to ask. And
can I say one thing, Raju? This is something that you've said, I've heard you say multiple times before, just for any of the fellows that are participating here on this conference today. It's very important for you guys to go and get hands-on experience seeing how these scopes are reprocessed. So I would encourage you, as Dr. Raju has done, to go and see how the scopes are done, maybe get your hands on and kind of wash and practice how the scopes are cleaned and reprocessed from the start to finish. I think that gives you a lot of knowledge and a lot of appreciation for the endoscopy staff that are responsible for reprocessing and sterilizing the scopes. It's, I would say, one of the most important jobs within the endoscopy unit is what happens in the scope reprocessing room. So I would encourage the fellows to get some hands-on experience doing that during your fellowship training, no matter what year of fellow you are. Even if you're a therapeutic fellow and you haven't had that opportunity in the first 3 years, I would encourage you to do that. And in fact, you know, all faculty, go and see how your endoscopy technicians and nurses are reprocessing in the room. See how much effort and labor they put into getting these scopes ready for the next patient. It's really an amazing job that they do. So I think it's worth our time to go and see what they do and congratulate them on their excellent work.
I want to make one comment that I've learned watching while I was shooting the video last week. We will use that video some other time. If anybody is designing an endoscopy disinfection unit, one thing is to keep in mind is the time it takes to fill the tank for you to submerge the scope. You know, typically you need a particular size tank, and that will take at least 10 gallons of water in each tank, or 8 to 10 gallons of water for a scope to be submerged with a loose coil of the scope. And if you really want to make that process efficient, and I'm making this comment for Denise's, for the sake of Denise, it takes a long time to fill that tank because the water tap bore is smaller than the drain pipe. If you really want to hasten that process, I would actually make sure that I have a very large bore water tap that can fill the tank very fast. Otherwise, I was thinking that, okay, how do I make the process a little more efficient? That is, I want to make the tank filling aspect as fast as possible. In the same way, the drainage should be as fast as possible, right? So that is an interesting observation and a learning point I had while I was shooting the video with and observing Tamitria doing the scope washing. And I want to thank you all, and I really appreciate you joining. I hope you find this useful. Next week, we're going to talk about electrosurgery. And this is basically for fellows, trainees, and nurses. How do you set up the machine? How do you use different parameters for different cuts and hemostasis? You all have a nice weekend. Thank you.
Thank you, Raju. Thank you, everyone.
Thank you, Dr. Raju.
Thank you,
Dr. Raju.
Thank you, Dr. Raju.
Thank you, sir. Thank you.